Let's hear from Samaresh before we take on and of course, our expert panel's view.
Yeah, I hope I'm audible, madam.
Yes.
Thanks a lot for inviting me for this talk. And I'm going to be discussing why not the newer generation of enhancing the depth of focus for post laser vision correction patients. And I just wanted to break the ice by saying that there are many types of lenses. We are not discussing diffractive lenses for my talk, which are also claimed to be EDOF lenses. We're discussing purely lenses which increase the depth of focus. And how they do it is by actually distributing the light intensity, as you can see over here. If I get move the cursor, a monofocal lens also has certain intermediate profile, but a lens that has an enhanced depth of vision will increase your length of focus, just like a shallow depth of focus lens, and give you a larger, more continuous zone of vision, which mimics natural vision. So it stretches and shifts your focus rather than splitting, as would a trifocal lens do, or any diffractive lens do. To address the elephant in the house, we've been using the Barrett-Truquet formula, and I think with that formula, we did do a study which we published, which was to compare the IOL prediction in both the prediction error and the refractive prediction error of 4 commonly used formulas. The Wang-Koch, Maloney, Shamas, and the Barrett-Truquet, which is available for free on the ACRS and APS-CRS as well. We found out that the prediction error was least with the Barrett-Truquet and also with the Shamas formula, and this was statistically significant compared to the other formulas. And we talk of refractive error prediction error also, it was the least with Barrett-Truquet formula, so we were well within 0.5 diopters for most of our patients. So I think at this point in time, with the kind of formulas that we have available, the ever prominent issue of whether we hit target emmetropia or not is less important in today's generation with the better formulas in it. And this is what we concluded, that all formulas performed well, and the highest number of eyes within 0.5 diopters was with the Barrett-Truquet, which fortunately for us is available for free. So with this, I will show you some real life examples rather than some theory, because this is what actually happens in the field. So this is this patient who's about 40 years old, and he's had Contura with me, femto LASIK, Contura vision about 5 years back. He landed up having a COVID infection and developed steroid cataracts in both the eyes, early PSCs, but being a patient with active lifestyle, he had to undergo surgery. Now, this is typically how a LASIK would look if it's done well-centered. This is particularly because it's a topography-guided LASIK. You can make out, if you look at it on the right side, that it's a fairly well-centered ablation zone and really well within the pupillary area. And this is the patient's not photopic, not mesopic, but an ambient light pupil, which is where he would be most of the time. And it's a very well-centered ablation profile. And so happened with the left eye. Now, when we plan a cataract surgery, particularly for patients who've undergone any sort of corneal procedure, one needs to keep in mind that what you need to see is the pupillary area or the pupillary axis and the zone of the cornea within the pupil. And the rest of it does not matter as much. But in this case, since it was a wide zone ablation, we safely went ahead and did a surgery and bang on target. This is just a screenshot from my EMR showing literally nothing came out in terms of subjective refraction. Obviously, the AR did show 0.25, 0.5 here and there. And the patient did need a +1 add to jump up from N8 to N6 with a little more ease. And the patient was extremely happy. This is to show you, just as a matter of concept, a preoperative aberrometry showing how classically clear the aberrometry of the cornea would be if the lasers have been done right. And since we're discussing a newer generation right now, and this is how typically a cataract would come up as an internal aberration in the eye. And this is just to show you the post-op of the same patient, showing how strikingly these lenses will perform inside the eye in terms of their optical quality, provided the cornea gives them good field to work on. At 2 months, he's okay. There's a 0.5 and his near unaided is N8, needs a 1.5. And with 1.5 with a little more mag is extremely comfortable. And that's a good post-operative patient with an EDOF lens. This was a VBT lens. This is another patient, 55 years old, and has had LASIK 30 years back, probably a microkeratome because she was operated in New York, because I think that was a fad then to go and operate over there. And this is how the cornea looks. Again, if you notice, it's still a relatively wide zone ablation, and within the pupillary area, it's a regular astigmatism. And the cornea is well-centered ablation. So it was a decently done surgery, and this is not a new surgery. It's been done many years ago, almost 3 decades ago. This is the right eye of the patient, and I think similarly the left eye of the patient in the right eye. And this is the aberrometry, again showing that even with an older generation LASIK done, but done in a nice, proper way, the corneal aberration profile is negligible to none. And whatever is happening at the level of the posterior capsule. And this is a very classical patient. So if you do your workup right, you look at the corneal profile, you understand the patient's requirement. I would go, the only reason why I would not offer them a multifocal lens, if at all, is because of glare and halos. That may be pertinent because of an older generation LASIK done, but an EDOF is absolutely no contraindication in such a clear looking cornea. This is where you really test the eyes. So there's a 72-year-old physician who's had an RK. Now, this is not laser vision correction, but just to prove the point out, in the end, is this is how the cornea looks for an RK patient.
Just 1 minute left.
Yes, please. 1 minute left. All right. So this is how a cornea looks. It's pulled out on 4 sides, but if you can make out the central cornea is still doing well, we use the online formula calculation, and this is where we landed. We did a bilateral vivity toric implantation for this patient, and we landed with a 6.9 unaided and with a 0.5 learning into 6.6. Patient again needs an add of 1 diopters. So not only for new generation LASIKs, but even for older generation, and even to go for so far ahead as to see regular corneas in post RKs and post conductive keratoplasties where we've done these surgeries. This is the same patient showing you the 4 RK cuts that were done some time back. The contrast and the mesopic contrast and the brightness contrast is also well within the normative range, and it's not dropping down with these lenses. And this is documented for all our patients post-operatively. The only thing that you need to tell the patients is they will need glasses for fine print of about 0.5 to 1.25, and there may be a marginal loss in contrast because the light is splitting, because it only is there much light to break up. Again, contraindications are irregular corneas, and that I think is a very simple thing to look into. The staff should be able to pick up irregular corneas and not advise such lenses. Or if you have decentered ablations, is when I will advise a non-aspheric lens monofocal to these patients' eye. The only reason why I would not do a trifocal is because they may land up with dysphotopsia, glare and halos. But I guess with the EDOF lenses, it's very satisfactory. The outcomes are extremely satisfactory, and the patient does appreciate good range of vision, and you get away with the negative dysphotopsias that probably would have happened had the patient used trifocal lenses. But it's always a good idea, just to end this talk, to always document the patient's mesopic pupil, because at the end of the day, what you're treating is the patient's dim lighting condition at best and not the bright light, because probably everyone will see good in bright light. So good workup can lead to a good outcome. Thank you.
Thanks a lot, Samaresh, for summing it up all very beautifully. So we have the expert view of Dr. Ramamurthy now.
I think excellent presentations by all three of them, as expected, sharing very similar thoughts to my mind. One of the factors for whenever we talk about presbyopia trifocals is that patient has to be motivated. The very fact that these patients went for a refractive surgery at their younger age group means that they are looking for spectacle independence, and they are prepared to deal with whatever baggage it comes with. And as in all cases, especially in these cases, we always tell them that though we might consider putting in a trifocal or a EDOF lens, there is some expected that it's not refractive accuracy that we'll be able to achieve in every case, but it's more a debulking of the total amount of refractive error that the patient has to deal with. And as Samaresh pointed out, they might need a small correction or a small pair of readers at the end of the surgery, though most often they would be independent or spectacles. Now, of course, one of the challenges in all these cases is that arriving at the correct refractive power that needs to be implanted. If you don't get that power correct, obviously leave on multifocality or the very fact that a residual spherical or toric cylindrical error will obviate the results. So nowadays we have excellent, as was pointed out again by all the speakers, access to excellent formulae. Our go-to formula is the Barrett 2K formula. And along with this, nowadays we have much of an advantage the total keratometry in virgin eyes. When you with this posterior cornea is altered, when using these 2K TK formula, definitely total the right formula, the right optical biometry is extremely important. And I would obviously monofocal is often the choice, except in certain areas where the age of the patient at which how many years back the surgery was done was also important. Because with some of the earlier lasers, the amount of aberrations that was induced, etc., was much higher. But if it was done in the later part, 2010, in the early 2020s, the quality of aberration itself is much better. And also the amount of refractive error that was treated, if it was a -8, -7, -5 with -4 diopters of cylinder, these obviously the corneas are less suitable for accepting the optics of a multifocal intraocular lens. But if it's a straightforward -3, -2.5 diopters power, which has been corrected as small hyperopic power, again, you can go ahead and deal with a multifocal intraocular lens. And the happiness of the patient that the patient had subsequent to the basic refractive surgery is also important. The patient was never totally comfortable post laser vision correction, had issues of halos, glare, etc., was never failing that he got optimal results. Such a patient might again not be a good candidate as far as multifocal intraocular lenses. But if the patient had excellent visual outcome after laser vision correction, was happy till the onset of cataract, then maybe these patients could be again considered for a trifocal or EDOF intraocular lenses. Then topography is extremely important, not only for making sure that if there is a cylinder, it's not an irregular astigmatism, but it's a regular bow-tie astigmatism, which can also be dealt with the intraocular lens that you are implanting. But also making sure there's not too much of higher order aberrations in the eye. There's excessive higher order aberration, which could be picked up on an eye trace or even in one of the modern day topographers. Then this might be a relative more than a 0.4 higher order root mean square. Then maybe this would be a relative contraindication as far as multifocal implants is concerned. A lot was being talked about by angle kappa, angle alpha, etc. But today, whether it's for multifocals in virgin eyes or for in post-refractive surgery scenario, I think it's less of importance, and more of us are realizing that we need not really emphasize too much on this. Maybe it's beyond 0.7, 0.8 millimeters, you might stay away. But even up to 0.7 millimeters, we go ahead and implant trifocal implants with reasonably good results. And I think did a right thing by differentiating when we came to EDOF lenses, differentiating with the VVT with the other lenses. VVT that EDOF lenses also includes other lenses like the Symphony, the AT Lara, etc. And those contain diffractive rings. So they are not much different from the trifocal implants. So when you are talking about optics, which is slightly different from the trifocals, basically VVT might be the way to go. And as was pointed out by Samaresh, there is literature evidence to support that these lenses are somewhat more tolerant to a certain amount of aberrations compared to a trifocal implant. So if you want a go-between, when you feel that cornea is not absolutely pristine and ready to receive a trifocal implant, then you could consider a true EDOF lens like a VVT implant. Of course, then you have the additional lenses like the monofocal plus, like the iHands or the Evolex from SIFI, which essentially play around with a slight bit of central curvature change. These lenses, of course, if the patient is not keen on the dysphotopsia that might come with it, but wants something additional, you could consider these lenses, which their optics are almost similar to a monofocal implant, but they give a little extra as far as the intermediate vision is concerned. Because whenever in doubt, whenever you feel that the patient's expectations are not likely to be met, the cornea is not pristine, there's a significant amount of irregular astigmatism or aberrations, then it might be a good idea to go ahead and implant a monofocal intraocular lens. But having said that, as was also mentioned, we are likely to deal with more and more of these patients as time goes on, and they would also expect spectacle independence. And maybe it has also got to be followed up with a procedure. You might do a laser vision correction even before doing the cataract, so as to deal with the higher order aberrations, the refractive error, get a better corneal stages by doing maybe a topo-guided ablation and subsequently implant a multifocal implant. Or if there is a residual error, you could do a laser vision correction. And of course, you could also implant a piggyback lens in case it is needed. I heard an interesting concept in this, just to conclude at the ECRS, where it was mentioned that implant a monofocal implant in the bag and put a piggyback trifocal implant in the sulcus. Wait for about 3 months in case the patient or with the multifocality, taking out a trifocal intraocular lens from the sulcus, the piggyback lens, is much easier compared to taking out a implant from that. And then you leave the patient behind with monofocus. So I think the kind of choices is limited only by the patient's expectations and by our imagination. And kudos to all three of them for giving a very comprehensive presentation. And I believe that there's much sense in what they said. Thank you.
Thank you, Dr. Ramurthy. Dr. Prema, I wanted to ask you a question here. Are you there, Dr. Prema? Dr. Prema, are you there?
Yeah, I'm here, Chitra.
When you are looking at doing a cataract surgery in a post-laser vision correction, would you think, look at the refractive error, do you correct a myope or a hyperope for a premium IOL? You think along those directions also, besides the choice of the IOL?
Yeah, I mean, I would say this, Chitra, I think for any patient who's undergone a refractive surgery, a corneal tomography is a must. Not only to look at, as Samaresh said, the centration, but if it is decentered, to rule out a post-LASIK ectasia. Because these eyes would then behave very differently, and all the calculations that you do, imagining that it is a stable refraction may not actually be there if it's a post-LASIK ectasia. So ruling out a post-LASIK ectasia is extremely important. And I would go along with all that has been said by the speakers as well as Ramu. He seldom leaves anything to be added. He's so thorough in the way he sums up things. Yes, I mean, if it is a well ablated cornea, I mean, if it's well-centered ablation, and the patient is willing to accept a small correction cornea, then as Samaresh would have done, I would think an EDOF lens is a good option. But if not, if the eye is aberrated and if there are any doubts about the ocular surface, as Dr. Vijay also pointed out, then that needs to be addressed. But if the ablation itself is not has not been well centered or something, then I would just stick to a monofocal lens.
In that viewpoint, I think I would also add that for a myope, even up to moderate myopes, and you could go ahead if the abrasions are not significant to do a premium IOL, but a moderate hyperope. Of course, nowadays moderate hyperopes also we don't do LASIK, but some of our early hyperopes whom we corrected and are coming for cataract surgery, probably we would think again because of the complex optics which a hyperope causes. So we may not look at a multifocal IOL in those eyes when we talk about.
But an EDOF lens is still is a good option even in those eyes.
Even in those eyes, yes. Yeah, thank you, Laura. Thanks a lot, Dr. Prema. Dr. Namrata, which would be the formula which you would say is the go-to formula? Are you there, Dr. Namrata? Like, you know, now there is ASRS, there's Barrett's, there's Haigis, which appears logical for you to approach?
So I would say that Barrett 2K is the one which is logical, but then again, I would still, I'll still try to find out what it would be with each of these three formulas.
Yeah, you would like to know what
are the other options?
Yeah. Gaurav, are you there? Just one line I wanted. What are your thoughts about the IOL of choice? Like, we know we would look more at a myope than a high hyperope. We would not do a high hyperope. We know about the formula that we would like to look at the three ways of doing it. What about the IOL of choice? What would you feel is the safest?
I most often end up using monofocals. I also end up using EDOFs fairly often. Very rarely I have used trifocals and I've got great results, but then all those things which were discussed are very, very important. But that would be a very, very select choice of patients where every criteria is met. So I'll end up mostly using either monofocals, but I don't hesitate to use torics if I have got a good I mean, good looking cornea with proper astigmatism. And I wanted to add to the formulas that we are also using ray tracing now. It's inbuilt into the anterior on which we are using. That seems to be giving good results in some patients, but Asker's calculator is what I would use because it includes the OCT based calculation, the pentacam based. So it has actually it goes beyond the 3 formulas that we are discussing. ASCRS also has options of adding sources, other sources. So I would strongly recommend that we use that.
Okay, thank you. Thank you.